Today I am presenting the case of Mr. ALB, 53-year-old gentleman, resident of Gaya, Bihar, policeman, informant being himself. History seems reliable. He was admitted on 4th of December 2022 and examined on 6th of December 22. He presented with chief complaints of swelling of body since last 4 months and shortness of breath since last 20 days. I would like to start my history 5 years back in 2017 when patient had road traffic accident for which he underwent surgery for fracture of left lower limb. And at that time, he was found to have diabetes and hypertension. He was started on 2 oral hypoglycemic agents at that time and 1 antihypertensive medication that the name of the medications not known to the patient. As per patient, he was compliant to medications but never followed up with the doctor. Neither he did got any tests done thereafter. He, although he used to have complaints of excessive thirst, passing large volumes of urine and increased appetite on more or less daily basis. There was no complaint of headache, blurred or decreased vision, tingling, numbness, chest pain, or any focal neurological deficit. Now, since 4 months, patient noticed swelling of bilateral ankles, which was progressive and used to be in evening initially. Swelling increased to involve thighs over next 15 days and complete lower limbs by next 1 month. Over next 1 month, face and abdomen also had swelling. There was no history of any chest pain, palpitations, or paroxysmal nocturnal dyspnea. No history of any abdominal pain, jaundice, hematemesis, bleeding PR, blood transfusion, or any high-risk behavior. No history of any recurrent loose stools. No history of any hematuria, frothy urine, decreased urine output. Although on direct questioning, patient had history of nocturia. He used to get up for around 2 to 3 times at night, and it was not associated with increased urgency or poor spleen. For the same, patient consulted local physician and underwent some blood investigations. At that time, he was initiated on medication that increased his urine output and decreased his swelling over the time. He was told to have a creatinine of 2.9 milligram deciliter at that point. He stopped his medication himself 1 week later and didn't follow up with his local physician. Patient started then complaining of shortness of breath in last 20 days, which was insidious, initially present only on exertion, usually on climbing only 1 flight of stairs. Over next 10 days, this shortness of breath progressed to the point where patient was unable to lie down and it relieved on sitting position. Again, there was no history of any chest pain, palpitations, or PND. There is no history of any abdominal pain, jaundice, hematemesis, no history of any recurrent loose stools. Patient consulted his physician once again, and he was started on tablet fusimide twice daily, which increased his urine output and decreased swelling and improved his shortness of breath as well. At this point, he was told to have creatinine of 3.1 milligram per deciliter, and he was also told that he was having proteinuria of 7 gram per day, and he was referred to our hospital. There is no history of any hemoptysis, cough, hematuria, oliguria, oral ulcer, joint pains, paresthesias, any analgesic use, alternative medication use, backache, fever, weight loss, or frequency urgency. In my past history, patient had diabetes and hypertension since last 5 years, but there is no history of any coronary artery disease, any cerebrovascular accident, or tuberculosis. Patient is vegetarian by diet with no addictions, normal bowel, but sleep disturbed due to breathing difficulty. Family history, significant family history is of father. He was having diabetes and was also told to have chronic kidney disease, but he died at the age of 62 years with unknown cause. Patient has 2 siblings who are normal and no comorbidities, and mother also didn't have any comorbidity. In my summary, patient is a 53-year-old gentleman, known case of diabetes, hypertension since last 5 years, with family history positive for diabetes and CKD, presenting with swelling of body of 4 months and shortness of breath of 20 days, found to have proteinuria and renal dysfunction.
Okay, Arpit, we should stop at the history, not going to examination right now.
Okay, sir.
So, you said that he had a history of diabetes and then for 5 years, and we do not know the level of control of diabetes. He has been compliant with medicines and he has also had high blood pressure. But you said he did not know the medicines he was taking. So, a person taking diabetes and hypertension medicines for 5 years, is it likely that he'll not know which medicines he was taking? And does that mean that is he really compliant or not? And was the history of compliance gauged by family members, whether he was compliant or not on this thing?
Actually, sir, the patient presented with his in-laws, and secondly, patient on repeated questioning told that he was taking medications on regular basis. He used to show the papers and just bring the medications. And regarding compliance, sir, it is possible because many patients just give the consultation papers to the pharmacist and they bring the medications. Otherwise, obviously, he was taking it for 5 years.
Sure. So again, in this, so what do you think is the cause of this swelling
What is the
and
provisional
shortness of
diagnosis?
breath?
Sir, the patient is probably having chronic kidney disease due to diabetic kidney disease, and he has landed up in fluid overload, sir, with diabetes, hypertension.
Okay, so yeah, so when you're looking at shortness of breath, swelling, you're thinking in terms of chronic kidney disease and diabetic kidney disease.
Yes, sir.
Looks one of the most plausible things. What are the differentials? Do you think it is all cardiac? He has been orthopnic for quite some time. So do you think there's a cardiac component? Do you think there's a hepatic component to these things? Before go to diabetic kidney disease, the differentials in other organs?
Yes, sir. On taking negative history, sir, patient didn't have any history of paroxysmal nocturnal dyspnea or any chest pain. So more or less,
he has been orthopnic. So that was the question, because you said no PND, but he has been orthopnic, not able to lie flat, right?
yes, sir. But orthopnea can be present in other than cardiogenic causes as well, sir.
In history, did you take a history of whether he had exertional dyspnea or angina? Was his effort tolerance going down in due time?
Sir, regarding dyspnea, in my shortness of breath history, I mentioned that initially patient had this exertional dyspnea on after on climbing one flight of stair. Patient used to feel dyspneic, and over the time, it became the one where the patient has become orthopnic. And this was preceded by swelling of the body. So probably the patient was having this swelling. Patient landed up in pulmonary edema and probably non-cardiogenic pulmonary edema, and the patient is having orthopnea.
Yeah, so the thing is that while you are biased towards this thing, which is quite obvious, we cannot rule out an underlying cardiac disease in this patient also, because he has been having orthopnea. There's a progressive effort intolerance, is not been to client stage for some time. So those should always be considered, because when you're considering a diabetic kidney disease, you're looking at causes are cardiovascular and infections. These are two things you have to look, and progression of kidney disease, of course. So a cardiac, this has to be considered always. Okay.
Sure,
okay. Now, so the next question that comes over here is that how much do you think it is a diabetic kidney disease versus a non-diabetic kidney disease?
Sir, the patient is type 2 diabetic, and patient family history is positive for diabetes and CKD. Father was having diabetes and CKD. So patient is now having renal dysfunction and proteinuria. So it goes more in favor of diabetic kidney disease rather than non-diabetic one. So
yeah, okay, family history, we understand that there's a family history of diabetes and a history of kidney disease. And we know that if a person has a family history of diabetic kidney disease, he's more likely, but we are not sure whether his father also had kidney disease because of diabetes.
Sure, sir.
Yeah. So now again, what are the ways you try to distinguish whether the person is having a diabetic kidney disease or a non-diabetic? When will you say that, yeah, it is a diabetic kidney disease, and when you will say it is a non-diabetic kidney disease?
In case the patient is having a timeline of diabetes and then patient present classically with the renal dysfunction, proteinuria, and in case patient is having diabetic retinopathy as well, along with that, if family history comes out to be positive, then it goes more in favor of diabetic kidney disease.
So you
Uh,
mentioned three things: timeline, retinopathy, and family history.
yes, sir.
Can you elaborate a bit more on timeline?
Sir, on timeline, usually it was given in like type 1 diabetes, but in that they used to be around 5 to 7 years before proteinuria develops, and then renal dysfunction for around 10 to 15 years, and the patient landing up in CKD around 20 to 23 years. But in case of diabetes type 2, it is difficult to say whether timeline can be maintained or not, because even in this case, patient came to know of diabetes when he had an RTA. Before that, he hasn't checked it anyway. So we can't tell whether since when the patient was having diabetes.
Yeah. So
I would say that what Rahul said is very relevant because when you are talking about orthopnea, whether it is fluid overloaded or whatever, for me, orthopnea most of the time means left ventricular dysfunction. And we all know that diabetics and CKD patients, 50% of them will have a major cardiovascular episode even before they reach dialysis. So, in all likelihood, he has significant cardiac disease. I would say that. And I would also like to ask you that how would further you differentiate, like Rahul said, that it could be a non-diabetic cardiac disease? What you could have got that would have made you think that it is like more non-diabetic kidney disease?
Sir, in case the patient had sudden and rapidly declining renal function, or there is a sudden increase in proteinuria, and there is
So
active.
rapidly declining renal functions, in which cause you think you will get diabetic declining renal functions? The RPG and AKI?
Yes, sir.
So there could be so many other causes which will fit this patient. His timeline doesn't fit you in RPGN, does it? It's
No, sir.
already like 4, 5, 6 months history.
No, sir.
So you would think more if you have some sediments there or some
Active sediments. Yes, sir.
non-renal illness. If you have some other history like that, you would be more inclined. So what you think are nowadays the prevalences of non-diabetic kidney disease and diabetic kidney disease? As of today, what are the prevalence in diabetics getting a diabetic kidney disease and non-diabetic kidney disease?
So basically, one third of patients have just diabetic kidney disease, then one third have diabetes along with non-diabetic kidney disease, and last one third just have non-diabetic kidney disease, sir.
Actually, it depends upon the criteria at which you biopsy a patient. Supposing if you biopsy a patient only when he has sediments, there is a short history, there is nothing on fundus, you will have more and more chances of getting non-diabetic kidney disease. But for example, if you biopsy 100 diabetics, irrespective of their further presentations, then the prevalence will be very different. Okay.
Okay, sir.
Whom do you think gets more diabetic kidney disease, females or males?
So females.
Okay. That is quite nearly true. And what would define, is there any difference between diabetic nephropathy and diabetic kidney disease?
Yes, sir. Diabetic nephropathy per se is the proven histological proof that the patient is having diabetic changes
Good.
in
Very
kidney
good.
biopsy, and diabetic
Very good.
kidney disease per se logical, but patient. Yes.
Yeah. Okay. Good.
Arpit, just a one small question I'm NPCing. What are the various phenotypes of diabetic kidney disease? Are you aware of various phenotypes, or do you think
Yes,
all
sir.
of them are similar?
Yes, sir. Patient can be like classical one is patient is proteinuric having renal dysfunction. Then patient can be directly having renal dysfunction without any proteinuria. Then patient can have proteinuria initially, but it regressed back to normal, means no proteinuria after that. So,
Quite right.
So that is
So
why
is there
Dr.
any
Singh-
change in this, what Professor NP Singh has said? Nowadays, is there any change in their presentations of phenotype?
Yes,
Are there
very
some major
important.
changes which are taking place?
sir, means it is mentioned in literature that 25% patients present with non-albumin, non-proteinuric DKD as such. So
Quite right. They will come with worsening GFR and
yes, sir,
rising creatinine.
without proteinuria.
May or
Yes,
may not have significant proteinuria. Earlier, most of them were having proteinuria. I think one of the reasons could be that early institution of ASARB,
Yeah,
which
sir.
is leading them to this problem.
very true.
Okay.
So I also agree with, you see, whenever you're presenting this case, you should mention that cardiovascular cannot be ruled out, especially these patients are likely to have no chest pain and asymptomatic coronary artery disease, right? Or they can
Okay,
have a
sir.
cardiomyopathy microvascular. So
Sure.
you just cannot dogmatically say that this patient does not have it. Okay? This all of us have pointed out, so this should be borne in mind very clearly.
Okay.
Okay, go ahead.
Coming to general physical examination, patient is conscious, oriented to time, place, person with the body mass index of 29.38 kilogram meter square, BP of 180 by 90 millimeter of mercury in right arm sitting position, and 176 by 90 millimeter of mercury in left arm sitting position. No evidence of any orthostatic hypotension, postural hypertension. Pulse rate of 86 per minute, regular, good volume, no radial or radiofemoral delay with all peripheral pulses present. Respiratory rate was 23 per minute, regular, abdominothoracic. Temperature was 98.2 degree Fahrenheit in right axillary. Pallor was negative, no icterus cyanosis clubbing lymphadenopathy. JVP was within normal limits. There was presence of bilateral pitting pedal edema, which was present up to the knee. Periorbital puffiness was present. Acanthosis nigricans and skin tags can be seen over neck. Multiple scars over left lower limb extending from knee to ankle seen. This was all in general physical examination, sir. On systemic examination, CVS was mostly normal. On inspection, precordium was normal with no scars, sinuses, no dilated veins. Palpation, apical impulse was palpated. All the lung fields. Hello,
Yes, carry on.
sir. Am I audible, sir?
Yeah, you are.
Yes. So,
But your video screen is not there for some reason.
But you have to share your screen again. I think that is connected.
Screen. Screen. Just a minute, sir. Sir, sharing nahi ho rahi hai. Can I continue without that?
Okay.
Okay. So, okay. ये यहाँ पे.
Yeah, you got it.
Yes, sir. On auscultation, there was bilateral infrascapular fractals heard over bilaterally.
Full screen कर दो बेटा, full screen कर दो.
Yes, sir. In CNS examination, higher mental functions were normal, cranial nerves were normal. Fundus showed soft exudates, and it was moderate non-proliferative diabetic retinopathy. Power, tone, and nutrition was normal. Bilateral ankle reflex were absent. Sensory was normal. Cerebellar signs were absent.
Ankit, I'm sorry to disturb you.
Sorry, sir. Yes,
Go
sir.
back on your CNS slide.
Yes, sir.
See, this is not the way you should, either you should say nothing, but if you say CNS motor, you don't do it the other way, power, tone, nutrition, normal. You do it nutrition, tone, then power. Okay.
Okay, sir.
It just shows the shabbiness of, because we all are MD also, and Professor Singh is there. Either we just say no abnormality detected, but if we are expanding, then the proper format central nervous system should be followed.
Similarly, sensory में बेटे sensory में ना बताना है क्योंकि you are dealing with a diabetic.
Diabetes.
Yes,
Yes,
yes.
sir.
You have to say whether what did you look for and what did you find. Sensory normal.
हो ही नहीं सकता जब तुम्हारा एंकिल जग रिफ्लेक्स
ankle
लॉस
reflex
है,
absent है ना?
हो ही नहीं सकता कि पोस्टीरियर
Posterior
कॉलम
column.
प्रिजर्व हो या
Posterior column
सेंसिटिव,
is
चलो
present.
कुछ ना कुछ लॉस जरूर होगा अगर एंकिल चला गया तो.
Okay, sir. So cerebellar signs were absent. Then per abdomen, shape of abdomen was globular, umbilicus inverted, no scar sinuses. On palpation, there was no guarding rigidity or tenderness and no organomegaly. Percussion, tympanic sound heard all over with no shifting dullness. And on auscultation, normal bowel sounds heard and hernial sites were normal. Urine examination, protein was 2+, no RBC.
Arpit, so
Yes.
again, a few things in your presentation. When you mentioned about the blood pressure, you said
pressure.
postural drop
Postural.
noted.
यही
You did not mention about the postural. If it was actually done, you'll be documenting that, okay, sitting was this and standing was this, supine was this and standing was this, which was not mentioned. So it means that probably it was not actually done. Again, sensory has not been done, which is seen. Third thing over there is that when you're saying that a person is obese and diabetic for this thing, you find that you don't even palpate a liver. So it's unlikely that we'll not find any liver over there unless there's a bit of cirrhosis setting in over there. So there's some doubts in your examination over there. A person is having orthopnea, a fluid overload, his fat is so highly likely that you should be able to palpate the liver also.
Sir, I tried to, but patient was obese and there was definitely no liver or spleen that was palpable.
Okay.
BMI कितना था बेटे?
Sir, BMI was 29.38 kilogram per meter square.
Okay, go
What
ahead.
is the importance of looking at the hands in a diabetic?
Hello.
What is the importance of hand examination in a diabetic?
Sir, hand examinations, we must see for nails, sir. Patient can have, in case patient is having nephrotic vein proteinuria, then patient can have Terry's nails, white nails. Then in case of patient is having BKD, patient can have half and half nail. Then there can be, sir, brittle nails or paronychia or nychonychia that can be present.
What are subcutaneous changes in diabetics, long-term diabetics? They can have uterine contracture. They very commonly, if you see a diabetic for more than 5 years duration, you'll find very commonly their tendon sheet would be thickened and their hands can be thickened, right?
Okay.
So a good student will always look for these changes. Similarly, you did describe about that, so those scars on the shin of the left knee, left leg. You should try to describe them in details. What do you think? Are they the previous infections which are there, or there are some changes which we expect in a diabetic in a skin?
वो सर ट्रॉमा हुआ तो उसको RTA था.
Oh, okay, sorry. I was not.
हाँ, वो RTA था sir.
अच्छा, ठीक है.
So go ahead.
Then on urine examination, there was 2+ protein present, no RBCs, sugar 2+, and 2 to 3 WBCs were present, sir.
Okay.
Examination done. So my diagnosis is patient is having chronic kidney disease stage 4 with diabetic kidney disease, diabetes with triopathy, hypertension and fluid overload.
What is the triopathy here?
Sir, patient is having nephropathy, retinopathy and neuropathy.
But okay. Okay. So why do you think it's diabetic kidney disease? The duration of diabetes was only 3-4 years. Can it be something else? I say here membranous nephropathy. What is against it?
Sir, first of all, the patient is having a prominent renal dysfunction. So and presented with renal dysfunction and
Membranous में नहीं होगा.
Sir, initially
primary glomerular injury में नहीं होगा renal dysfunction की proteinuria. Membranous, FSGS, MPGN.
Sir, definitely it can be present, but patient is having a positive family history of diabetes and CKD.
So diabetic is not immune to get another infection, another problem. Sometimes you have diabetes with FSGS. I'm sure you must have seen with membranous nephropathy.
Yes, sir. Yes, sir.
So how will you discriminate it further?
So we can get the anti-plateau done, sir.
Anything else?
So again, over here, definitely because retinopathy is there that you're seeing, which is non-proliferative. So you will tend to, most people will tend to say that it is a diabetic kidney disease with diabetic nephropathy because retinopathy is there and you're finding neuropathy also over there. Again,
yes, sir.
Do you think the rate of swelling that he developed, is it so fast? The progression is so quick in a diabetic kidney disease that within 3 to 4 months, a person goes to NSRK from virtually no symptoms prior to this. So how commonly will you see that? And could it still be an associated additional disease over there?
Sir, they can be, as you pointed out earlier too, patient can have microvascular complication of diabetes. Patient may be having cardiomyopathy and that has led to pulmonary, NSRK and pulmonary edema. Again, diabetes can be associated with NASH, sir, and that can be a cause of liver disease. But again, overall, when we see the negative histories and the examination, per se, liver and cardiac are more or less on the lesser side. So mostly it seems that chronic kidney disease and this has been the cause of fluid overload, sir.
What is the impact of obesity on the kidney?
Sir, obesity definitely again is associated with the obesity-related glomerulopathy, that is focal segmental glomerulosclerosis. But again, the patient's BMI is within the pre-obesity range, sir. And
right. But you mentioned that he is obese, so you need to understand the Indian or the South Indian classification of obesity.
Yes, sir. He is in pre-obesity range, sir. So as per Asian guidelines, it's up to 23, it's normal. 23 to 24.9 is overweight, and 25 to 29.9 is pre-obesity. Pre-obesity, and then 30 to 40 is stage 1, and more than 40 is morbid obese, more than 50 is super obese, sir.
So you may be right that this patient might be having predominantly a diabetic kidney disease because of, as Rahul has clearly pointed out, that because of the fact that he already has a proliferative retinopathy and other
Yes.
thing, diabetes. However, I would still like to rule out an underlying non-diabetic kidney disease, which can, as was pointed out by you, only can occur in almost two-thirds. And also, I would like to rule out other organ dysfunction like diabetic cardiomyopathy or asymptomatic. That is what your diagnosis should be. You cannot emphatically say that this patient has a CKD4 with diabetic kidney disease. Many a time, see, the person is the same, the vascular is the same, but vascular endothelium is the same. What stops the patient from having a macrovascular disease as well, right?
Yes, sir.
And very rightly pointed out by Rahul that blood pressure for a nephrologist is extremely important. You should have done at least the sitting and lying with the dysautonomia can be very well present, though he's a bit younger. And normally they have an atherosclerotic disease. So a lot of things can be made out of the blood pressure. Okay?
Sure.
So, Arpit, what do you think went wrong? A person in today's scenario, within 5 years of diagnosis, a young person, 53 is young, ends up in such a big complication over here. So, what should have been done, and what were the missed opportunities over here?
So first of all, initially at the point when patient was diagnosed as diabetic and hypertensive, and in the span of 5 years, we don't know what the status was exactly. So patient must have visited or consulted with the doctors on regular basis.
Okay, so you say that he is in police, right? And so at this stage, they must be having a regular checkup over there. Did you find out whether they were having a regular?
I again asked about the same thing, sir, but he told that nothing of such kind was done. So, as per profession, I asked about it, but he refused for it.
Again, because there are certain professions in which you do a regular health check. So don't you think that in the police or army, they do more checks and they would have detected diabetes early? And in that case, it should have been just a 5 years, not a misdiagnosis for a long duration.
True, sir. True. I asked regarding the same, but the thing is, the patient came to know of diabetes and hypertension only when he had RTA. Even before that, he wasn't having any like regular checkups or anything.
Okay, so when he had all these scars, you inquired whether the scars healed properly at that time, or were there any pus discharge from these scars, and did they take a longer time to heal? And what could be the relevance of this history?
No, sir, I missed it.
I think that is very relevant. The point Rahul
Yes,
is
sir.
making.
Yes,
It
sir.
could have given exposure to more NSAIDs. Maybe if there was some non-healing, then something like chronic your bone
Osteomyelitis, chronic inflammation.
osteomyelitis,
Yes, sir.
all
But
some amyloidosis, something like that.
nothing of such sort of any fever or any bone pains, any such things that didn't come up in the history in between, because he used to say that for the 5 years he used to take medications and followed up. So probably he may not be requiring anything.
No, but to be fair to that history is little opaque. So we cannot say with confidence that that RTA had no bearing on his further course of action. It may or may not have had. Okay.
Yes, sir.
Okay. So how will you manage him now?
Sir, since the patient is having diabetic kidney disease, so the patient should have proper glycemic control, proper BP control, and then RAS inhibition, RAS blockade should be given, and other cardiovascular mortality improving drugs should be added, sir. Then
Like,
patient, sir,
like
like SGLT2 inhibitors, sir, and mineral mineralocorticoid receptor antagonist, sir.
Okay, before going that, tell me what happens, what goes wrong in diabetes? Can you throw some light on the pathogenesis in a diabetic kidney? Clinically, what is the most early sign which you should suspect that this patient has diabetic kidney disease? Clinically, supposing you're sitting in a health unit, you're not sitting at Gangaram or in a smaller place, can you be doing some basic stuff which could give you some clue?
Sir, urine dipstick. The
Microalbumin.
patient is having proteinuria.
Microalbuminuria.
Yes, sir. Patient
And
microalbuminuria.
around that time, they will lose their nocturnal dip of blood pressure. This is extremely common. Extremely common. Along that time, you will have no other change, but if they do their 24-hour ambulatory blood pressure, they will lose their physiological nocturnal dip.
Yes, sir.
So that is important to remember.
Yes, sir.
Is the term microalbuminuria used, Arpit?
Sir, now it has been replaced with moderately
mild, moderate, and severe.
Yes, sir, mild, moderate.
Yes.
Yes, sir.
So, you see, you must now be aware that in 2022 now the KDOGI guidelines have clearly brought out management of diabetic kidney disease. So when you are asked about the question of management, it has to be a comprehensive management, starting with lifestyle,
lifestyle
diet,
management.
then
Yes, sir.
step approach, that pyramid approach or that triangle approach where you will like to give cardiovascular protection to everyone, and if possible SGLT2. If you don't say that I'll give it to everyone and I'll give ACE inhibitors, SGLT2, all of them together, patient will go into. So you say that I will evaluate, I will start. If the patient is not already on ACE inhibitors, I'd like to start. But what is the algorithm for starting ACE inhibitor in stage 4 chronic kidney disease? And also SGLT2 inhibitors, till what GFR you would like to be comfortably adding these drugs, right? So these are very important because now the patient's already reached. And the most important thing here was probably a family history, because all diabetics may not go on to develop diabetic kidney disease. Here, it's progressed very rapidly. And as has been pointed out by others, there must have been an acute on chronic. There must have been some, factor which would have, worsened his progression. So that is very important to delineate, because these are the reversible or preventable factors in future. Okay.
Yes, sir.
So tell us, how would you start ACE inhibitor in such cases?
Sir, we'll be starting with an ACE inhibitor or an ARB, and over next 2 to 4 weeks, we'll be seeing his serum creatinine and potassium levels. If the decrease is not more than 30%, within 30%, then we can maximize the tolerable dose, and the hyperkalemia is within limits. If there is more than 30%, then we need to withdraw, sir.
You need to withdraw.
Yes, sir.
There are algorithms now where, again, in that this thing, that there are 3 ways of starting. If the patient does not have a worsening of creatinine, no significant worsening, no hyperkalemia, you can gradually, in this case, because the ACE inhibitors, ARBs also get excreted through the kidneys, obviously the dose required would be much less, but gradually you have to escalate, because despite of our best efforts, because despite of our other things, these are still one of the very good drugs for still further progression. And there's been no now debate on that these are good. Similarly, if hyperkalemia is the issue, then we should try to take some other measures.
Potassium binders, diuretics. Yes, sir.
So in the early diabetic nephropathy, how do the damage starts? Can you tell us a little bit about the pathogenesis?
First thing, क्या होता है बेटे?
Sir, there is increase, there is increased advanced glycation end products that forms due to increased glucose in the urine, sir. And there is hypertrophy, there is more activation of SGLT1 and SGLT2 in proximal tubules, sir. But since there is excess glucose that is being filtering. It takes um, there is more of sodium along with glucose that is taken up. So glomerular feedback gets less, and there is glomerular hyperfiltration, glomerular hypertension that occurs. And and also the glucose that goes on the basolateral side of the proximal tubule causes the mesangial matrix expansion, as well as the uh, increase in fibro, as well as initiation of fibrotic changes. Sir. Then there is, sir, these advanced glycation end products that form, and there is a reactive oxygen species causing oxidative injuries, and furthermore causing the inflammation and the fibrosis. Sir. So
So
initially,
what is the earliest pathology if suppose I have to do a biopsy in such patients as a part of my study in the
yes, sir.
early diabetic kidney disease? What changes do you find on light microscopy?
So,
Okay, that's what. So
okay,
listening,
earliest is, sir, GBM,
yeah,
glomerular
thickening
basement thickening
and
that is
mesangial
seen.
expansion, right? And then subsequent.
Mesangial expansion, yes, sir.
So I have a very basic question to ask you, which 90% of the DNBs also don't answer. What is the normal filtration of albumin in a normal person? How much albumin is filtered in 24 hours in a normal person?
Sir, usually the excretion is less than 30 milligram per
I
day.
did not ask you about
Yes,
excretion. I asked you how much
Filtration.
proteins are filtered by the glomeruli in 24 hours.
yes, sir. Actually, they are reabsorbed in the proximal tubule.
Yeah.
So,
So around 3.5 to 5
0.5.
gram is filtered daily. But as you have said, almost 99.95% gets absorbed, only 30 milligram of albumin and 50 milligram. This should be known to you because this
Yes, sir.
mechanism gets exaggerated in patients with any proteinuric or podocytopathy. Okay? ठीक है.
Yes, sir.
So in a diabetic, at the afferent level, what changes would you expect at the afferent arteriole level, and what you can do about it? Like you said very clearly, very rightly, that SGLT1 and 2 are in the hyperfiltration mode because of more sugar and salt sitting in the proximal tubules. So proximal tubules are hypertrophic. What can we do about the afferent arterioles? What are the factors which cause afferent arteriolar resistance or reduction in resistance or increase in flow at the afferent arterioles will further injure the already injured glom?
So basically, hypertension is associated with diabetes, and that is one of the things. Then, sir, the vasodilators like endothelins and prostaglandins that act and cause the afferent vasodilation. Then, importantly, tubular glomerular feedback that causes the dilation of afferent arterioles, because there is less of sodium reaching to macula densa. And fourthly, sir, even the myogenic reflex, the auto regulation of hypertension is not equal, not there in diabetic kidney disease, sir.
And beside that, the friendly vasodilators like nitric oxide and all those things will be reduced.
Decreased,
right?
yes, sir. Yes, sir. These will be decreased.
Right. So can you classify the recent classification for diabetic nephropathy? Can you tell us something about it?
Sir, the Renal Pathology Society classification. So initially in class 1, there is thickening of glomerular basement membrane. Then in class 2, it's divided into 2A and 2B. Less than 25% of mesangial expansion in class 1, more than 25% mesangial expansion in class 2. Then class 3, even presence of a single KW lesion tells us that it's class 3. Then class 4 is diffuse glomerulosclerosis, that is more than 50% involvement. Then there is a presence of IFTA, in which scoring is done. If there is no IFTA, it's 0. Then if it's up to 25%, it is equated as 1, 25 to 50 as 2, and more than 2 as more than 50 as 3. Then the vascular, the interstitial inflammation present, if absent, it's 0. If present within the IFTA part, then 1. If in the normal part, then it's 2. And the arterial part, we see for hyalinosis, at present, if
Right.
absent, it's 0. Then less than 25, more than 25, 1, 2. Then arteriosclerosis, that takes for the intimal thickening. Against
Yeah.
the less, yes, sir.
So, if you genetically, what are the 3-4 more important like pillars which causes diabetic nephropathy?
So first is glomerular hyperfiltration and hypertension.
No, I would
And
say glycemic injury,
yes, sir, glycemic injury.
hyperglycemia, like glucotoxicity, right?
Yes, sir.
Metabolic. Then
Metabolic.
second is, as you are saying very correctly, hyperfiltration injury, hypertension, hyperfiltration injury. What is
Yes,
the
sir.
pressure at the afferent arterioles? Blood pressure at the afferent arterioles?
Sir, it is almost equal as the systolic BP, sir.
No. कैसे झेलेगा afferent arteriole?
ऑटो रेगुलेशन होता है ना बेटा
60 to 130 के बीच पे रहता है सर, तो mostly
Much less. Okay, so one is hyperdynamic glucotoxicity. Third is
third
I'm
is
asking for a reason.
innate immunity and
No.
inflammation. Inflammation. Yes, sir.
So, is there any particular cell if you find on a biopsy which is a very inimical of a bad outcome?
Yes, sir. Lymphocytes, sir.
Monocytes.
Monocyte. Sorry. Yes, sir. Monocyte.
Because of the inflammation, and this inflammation so far we have not been able to handle, and perhaps that is also one of the reasons we are not so successful in handling this disease. Okay, go ahead, Rahul.
what advice would you give it to your patient this patient, what advice would you give? Stage 4 में तो आ गया है, blood pressure 180 90 है,
Yes, sir.
diabetic non-diabetic non-proliferative retinopathy है,
Yes,
तो
sir.
क्या समझाओगे पेशेंट को, क्या बोलोगे, कैसे समझाओगे, क्या एजुकेट करोगे?
Sir, again, as you said, sir, comprehensive management should be done. Patient should be educated about the nutrition and the exercising. Then definitely adequate control of hypertension. Then adequate glycemic control. Then patient should be told that since the patient is having retinopathy and is having diabetes, so he must be followed up on annual basis. He must get his HbA1c done every third monthly. And then sir, as after evaluation, would like to add drugs like SGLT or mineral or receptor antagonist. Then statins that should be added, sir. And in case of cardiovascular, secondary prophylaxis for antiplatelet should be looked for.
What about dyslipidemia?
So statins, I told you.
Okay. And you won't tell him about future of the kidney?
Yes, sir.
Will you counsel him?
Yes, sir, definitely, sir. I will be telling him that diabetic kidney disease is per se a progressive disease, and it can progress very fast. So patient should follow up regularly and may be needing renal replacement therapy soon. So he must be first of all prepared for this, and then as per visits, I will be telling him when to get the AV fistula done, and whether if possible patient can go for transplantation, then later on he can be.
Agar patient transplant, he wants to go for transplant,
Yes, sir.
and he has like diabetes, like polycystic kidney disease, it will be like other family members will also be affected.
Yes, sir.
And he has a mother with 65 years of age and who is also a diabetic on 1 or 2 anti-diabetics.
Yes, sir.
And he has a son who is not a diabetic.
Mhm.
Whom would be your first choice donor?
Sir, since the patient is 53 years old and
No, I say he was 45, 50. His mother is 66, 65, borderline, marginal donor.
I would still go for mother, sir. Since the patient is above 40 years, so expanded donor criteria KDPI, we can look for additional factors.
What are they?
Sir, in case if kidney donor profile index is more than 85, we can go for a transplant in a diabetic kidney disease patient. So it includes whether the age of the patient, the ethnicity of the patient, creatinine level, or the hepatitis C status, diabetes, hypertension. So in that case, we can go for the transplant with the mother, sir.
Quite right. And you not prefer the son? He is not a diabetic?
Sir, son has a positive family history. He may be having diabetes and kidney
Down the
disease
line.
in the, yes, sir.
Quite right. Before progressing to transplant, what essential tests you will do in this patient? With this history, your patient.
Yes, sir. Since he's a diabetic kidney disease patient, I would like to do an angio to rule out coronary artery disease, sir, and also look for peripheral arterial disease because external IVH has to be done.
And if you come back to the conservative management, he's at 4 creatinine, right? 4.
Yes, sir.
What are the other strong things you could do to hold the disease here?
Sir, again, sir, proper BP and glycemic control along with the proper exercising, and that is 150 minutes per week. And
You have said nothing about his sodium intake, nothing about his fluid
yes, sir.
intake. That is,
Yes,
BP
sir.
will never be controlled if you don't control his sodium.
That yes, sir. BP.
How will you find out that he is not a defaulter on sodium? He says, "मैं खाई नहीं था."
So BP will not be controlled. Patient will be having fluid overload. And
can you do anything else to find out whether he's really compliant or not?
urine sodium. Yes, sir.
Urine sodium देखोगे ना, but
yes, sir. Yes.
If he is passing, but it may be vitiated by the diuretics, but still some idea you can get.
Yes,
right?
sir. Yes, sir.
Some idea you can get. How can you find out that this patient is catabolic or he is in neutral nitrogen, like he is not catabolic? Is there any way to find out?
Sir, if the patient is losing weight and
lose weight? वो तो इतना पानी भरा है, कहाँ lose weight? तो बढ़ ही रहा होगा weight.
Sir, basically the dry weight is decreasing and the
so
arm circumference,
edema,
arm circumference is decreasing, sir. So,
they are very fallacious tests. Do them very properly. Very fallacious tests in the presence of edema and all those tests.
Sir,
any other thing you can do to find out whether he is in neutral nitrogen balance or he is catabolic? Any relevance? अभी diet की बात कर रहे हैं, sodium की बात हो गई, fluid की बात हो गई.
Yes, sir.
Now let's go on protein and nutrition. How to find out whether he is catabolic or he is not catabolic?
Sir, besides general examination, we can look.
Beta, you will not be able
Yes,
to
sir.
find out because this edema is going to be a spoil sport.
Yes,
It
sir.
will throw a big spanner in all your anthropometric problems.
Yes,
Okay.
sir. Yes, sir.
So, okay, I will give you a clue. What is the normal osmolar load a person excretes every day? You understand the question?
No,
What
sir.
is the osmolar load that you are excreting? Like if you are 60 kg, what is the load you are excreting in the normal kidneys? If you are 60 kg person with the, I would say, medium to sedentary to active lifestyle, you are leading and you are a registrar, so you are obviously running much more than I am. So what would be the osmolar load this person would be having? That will give you a clue. But you'll only do it if you know what is the osmolar load. So what is the osmolar load?
Sir, he is diabetic, so he must be already having higher osmolar load than the normal.
So, quite right. So what is that osmolar load? What it will depend upon?
It will depend on the
It will dep-
muscle mass,
It will depend upon
nutrition
what?
status of the patient.
So, तो अंडा मुर्गी वाली बात हो गई ना. न्यूट्रिशनल स्टेटस स्टैब्लिश करने के लिए वी आर कैलकुलेटिंग ऑस्मोलर लोड.
Yes, sir.
So by doing the osmolar load, you will get some criteria. The nutritional status is getting vitiated here by the presence of severe edema that he is having, which is making him orthopnic. He is ascitic. He is having fluid right up to his chest. Right?
Yes, sir. Yes, sir.
That is going to destroy your most of the anthropometric markers. You may take help of albumin, you may take help of transferrin, pre-albumin, cholesterol. They are other biochemical factors you may help. But the best way to find out if a patient is catabolic, you calculate his osmolar load, which will depend upon the urinary sodium and the appearance of urea in the urine. How much urea is passing in the urine? A normal Indian diet person would pass about 500-600 osmoles per day. Westerners pass out 800,000 milliosmoles per day in 24 hours. So if he is catabolic, A, his creatinine rise would be higher. B, his osmolar load will be higher. Protein, nitrogen appearance would be higher. And he will be not maintaining his normalized protein catabolic rate. You will get some idea that he is inadequately nourished or he is catabolic. Okay.
Okay,
That
sir.
is where the importance of osmolar load comes. Okay. You will do sodium calculations, water calculations, proteins, diet, calories. What else you will do here? Medications.
Sir, medications again for glycemic control. Since the patient is already CKD4, then we can look for
ये
either
तुम्हें clinically
GLP insulin.
CKD4 कैसे पता लगा? How did you know CKD4 है clinically?
Not clinically, he was told to have, sir, serum creatinine of around 3.1 milligram per deciliter. Yes, sir.
So what else will you do?
Here it is an important question that he has one value of creatinine 3.1. He has come to you in fluid overload, possibly a cardiorenal syndrome. So can you really label it as a CKD, or do you think there's an acute component, and once you control his blood pressures, you control his fluid overload, you manage his salts, actually the creatinine may come down? So how confident are you about CKD4, and how confident are you that you ruled out an AKI component over here?
Sir, even after 3 months ago, when he went for just edema to the physician, he was told to have creatinine of 2.9 milligram per deciliter. And now he's having 3.1 milligram per deciliter. So that does not fit the criteria of acute kidney injury, sir.
So do you think he did not have any cardiorenal component to his this thing? And do you think once you control his blood pressure, reduce the congestion that he's having, will not improve at all?
Sir, since there has been an interval of 3 months, sir, it is difficult to say that.
I think we are over reading into it. We see a lot of people who do revert out and improve out from this stage over there.
Absolutely.
So you should first give a full trial. You should not label a person as CKD just on this basis. First, you should settle all the acute factors. You should control the anemia. You should control salts. We are not even sure whether he got good and proper medicines in this free time. You don't have a proper medical history over there. And obviously, his fluid overload into this degree. He's just been started on diuretics recently. We're not really sure if there's reversible. We are not sure that we have ruled out a associated UTI over here, though, okay, there's no pyuria over there, but there are a lot of factors that are to looked into, and you have to first optimize before labeling a person as stage 4.
Okay, sir.
Okay. So suppose this patient comes to you with severe hypertension and flash pulmonary edema. What would you suspect?
Sir, patient may be having renal artery stenosis secondary to diabetes, atherosclerotic renal artery stenosis, sir.
So in which case, how would you proceed further? How would you, after managing the patient, how would you investigate?
So initially we'll get a renal Doppler done, and
RI? What is RI?
it is resistivity index, and it sees the calculates the resistance within the renal vessels from renal artery to arcuate one. Then if it's more than 0.7 to 0.8, we can say there is increased resistivity index. So after that, if it's present, we can go for CT and MR angiography of the CT or MR angiography of the renal vessels. And if they do show renal artery stenosis, and we can go ahead with sir, the stent
So we have three
angioplasty of the
options.
renal
We have
artery.
medical management, we have angioplasty, we have surgical correction. So which is, what do you feel in terms of prognosis, which is likely to benefit?
Sir, obviously, if the renal artery stenosis is within 60 to 80%, then we must go for angioplasty, because this can help in reversing the may be helpful in reversing the renal dysfunction as well. And if it's obviously totally 90 to 100%, then we have to go ahead with medical management.
Many studies have been done. They hardly seem to agree with what you're saying. But anyway, okay. So what are the challenges which we face when we take these patients up for hemodialysis? Suppose you have to give an option to him for renal replacement. He's not ready for a transplant. So which one would you prefer?
Sir, it's a shared opinion and shared choice that has to be done. So we can give him we have to give him the choice of both peritoneal dialysis and hemodialysis as well. And within the first 2 years, we know that if the patient is having residual renal function, then peritoneal dialysis has a bit of edge over hemodialysis. And also in terms of cardiovascular mortality, within the first 2 years, peritoneal dialysis has an edge over hemodialysis. So we have to give both the options, and it's in shared opinion, whatever patient wants to go with.
Very good. So all the three have to be explained, and it has to be a shared decision, and they are all complementary to each other.
Yes, sir.
Okay. I think very well done, and most of
Yeah.
the questions you have answered.
Yeah,
And,
I think so. Well, Rahul, anything else before we close it?
I think so. It's fair, but
Yeah.
the main thing is that have to be more careful. We should not label CKD
Yes.
so quickly.
Yeah.
Because if a good trial, a lot of people improve out, and
I agree with you. Yes.
it's an important part, because AKIs are very common as a part of continuum of CKD and diabetic kidney disease, and a lot of time treating them is very rewarding also.
Yes.
Yeah, absolutely. Very well said, Rahul. So in the end, I'll just ask you a little bit about Figaro and Fidelio. Which was the kidney trial?
Sir, Figaro, sir.
No, it was Fidelio. Fidelio was primary kidney outcome. Figaro was primary cardiovascular.
Primary cardiovascular.
Okay, I think you did very well. Thanks you. You
Thank
lived
you,
up
sir.
to your alma mater. Thank
sir.
you. Thank you, Dr. Professor Singh. Thank you, Rahul.
Thank you, sir. Thank you.
Thank you,
I
Puneet.
learned a lot.
Thank you so much,
Thank
sir.
you. Thank
Thank you
you.
for giving your valuable time.
Thank you. Thank you.